Imagine a patient sitting right there in exam room 3. You walk in, and they are leaning forward, clearly in respiratory distress.
Yeah, pretty much a typical Tuesday shift.
Right. They've got a thick, productive cough, a fever that spiked aggressively overnight, and this is the kicker. The rapid respiratory viral swab you just ordered right there at the point of care just came back positive. So you are looking at the chart, you're looking at the patient, and the question hanging in the air is, what is the exact next right move?
Well, it sounds like the absolute bread and butter of acute care, honestly. I mean, you see a presentation like that almost every single shift.
Absolutely.
But the reality is that scenario is just a complete minefield of clinical decisions. It is a moment where deeply ingrained clinical instinct and, modern evolving evidence often just collide directly with one another.
I'm Dr. Taylor.
And I'm Dr. Griffin.
Welcome to our deep dive into the 2025 American Thoracic Society update on the diagnosis and management of community-acquired pneumonia, or CAP.
Which is a massive update, by the way.
Oh, it really is. And our mission today is to distill these brand new, incredibly dense guidelines into actionable insights. We want to take that raw data and translate it so you can make evidence-based, confident decisions right there at the bedside when you're staring down that exact clinical scenario.
But before we go any further into the data, there is a crucial medical caveat we have to establish right up front.
Yes, absolutely.
Absolutely. None of the recommendations we are discussing today apply to immunocompromised patients. That is a hard boundary.
Right.
There are entirely separate, highly specific guidelines for that population because, frankly, their risk profiles, their immune responses, and their typical pathogens are just vastly different from the general population.
It's a critical distinction to keep in mind as we navigate this. And just a quick reminder for everyone listening, if you find this deep dive valuable to your practice, please like, subscribe, and share it with your colleagues.
Definitely.
Our overarching goal is to elevate the standard of care across our clinical community, and widely sharing this knowledge is exactly how we achieve that.
100%.
So if we look back at that patient vignette we started with, the very first step is obviously confirming our diagnosis. For decades, the absolute knee-jerk reaction to suspected pneumonia has been to, well, order a standard chest x-ray.
Yeah, it's just muscle memory for most of us at this point.
Exactly. But these 2025 guidelines bring a very modern alternative directly to the forefront.
They really do. The ATS is now explicitly suggesting that lung ultrasound, or LUS, is an acceptable diagnostic alternative to a traditional chest x-ray for suspected CAP.
Which is huge.
Right. We are moving away from relying solely on radiation-based imaging and looking at what point-of-care ultrasound can actually reveal about the lung parenchyma at the bedside.
Okay, let's unpack this from a high-level evidence perspective, specifically looking at the grade methodology the guidelines use to weight their recommendations.
Yeah, let's get into that.
It is really telling that the ATS framed this as a conditional suggestion based on a low certainty of evidence.
Meaning what, exactly, for the listener?
Well, that terminology means this isn't coming from massive, randomized, double-blind trials comparing ultrasound to X-ray side by side across tens of thousands of patients.
Right, we just don't have that data.
We don't. Instead, this push is heavily driven by observational studies, a growing body of clinical experience, and really just pathophysiologic rationale.
Which makes sense mechanically. I mean, normal lungs are full of air, which scatter sound waves.
Exactly. But when pneumonia fills those alveoli with fluid and inflammatory debris, it creates an acoustic window. The sound waves can suddenly travel through, allowing us to visualize the consolidation.
Yeah.
And when you look at the downstream benefits for the patient, they are incredibly compelling. You're talking about immediate bedside convenience,
Yep.
the complete avoidance of ionizing radiation exposure, and perhaps most importantly, avoiding the high risk and steep cost of sending a borderline patient into the scanner for a CT.
Yeah, the bedside benefits are undeniable, but we have to aggressively ground this in frontline reality.
Fair enough.
Because the absolute linchpin of this entire recommendation is that lung ultrasound is only suggested where appropriate clinical expertise exists.
Right. It's not magic.
No, not at all. What's fascinating here is how heavily operator-dependent this diagnostic tool is compared to an X-ray.
Oh, absolutely.
If you don't have the specific training to recognize the sonographic artifacts to differentiate a true B-line from a comma-tail artifact, or to identify subpleural consolidations, the tool is practically useless.
It really is.
And even if you do have that expertise, there are massive frontline obstacles that weaken this recommendation the exact moment you step into the room.
Like patient factors.
Exactly. If your patient has severe obesity, the ultrasound simply cannot penetrate deep enough to give you a clear image.
That makes sense.
Or if the patient has surgical wounds, bulky chest tubes, or subcutaneous emphysema, the sound waves are just blocked.
Oh, wow, right.
Or just consider the patient who is in so much respiratory distress, they physically cannot hold the required positions for a full lung sweep. In those cases, you aren't going to get a diagnostic image no matter how skilled you are.
Yeah, the physical limitations are real.
Furthermore, if you're working a shift and have any clinical suspicion of an alternative diagnosis, say, you are worried about a pulmonary embolism or an underlying malignancy, ultrasound isn't going to cut it. You desperately need that wider, more comprehensive field of view that only an X-ray or a CT can provide.
So it essentially operates like a high-performance sports car.
That's a good way to put it.
Right. Like handing a clinician a bedside ultrasound is giving them the keys to a machine that yields incredibly precise, rapid results. But that speed and precision only matter if the operator actually has the specialized training to drive it on a track.
Exactly.
If the expertise isn't there, or the road conditions are terrible, like the severe obesity or surgical wounds you just mentioned, doesn't that sports car quickly become a massive liability?
It absolutely does.
You risk a false negative because the operator completely missed a small posterior consolidation, or you get a false positive because they misinterpreted a normal pleural artifact as an infection.
And that liability is precisely why the ATS frames this conditionally. Is pushed into the hands of an untrained clinician or used in the wrong physical context, you might falsely reassure a patient and send them home.
Only for them to deteriorate rapidly into septic shock a day later?
Exactly. The guidelines are effectively telling us if you have the specialized skills and the right patient, drive the sports car. It's objectively better for avoiding radiation and speeding up triage.
But if you lack that training?
Or, if the patient's body habitus fights you, stick to the reliable sedan or to the chest X-ray, because the downstream consequences of a delayed or completely missed diagnosis of pneumonia are severe.
Which naturally drives us to the next critical decision point in our workflow. So we have our imaging, whatever modality we chose, and we have definitively confirmed the presence of a lung consolidation. Now, we have to factor in that positive viral swab from our opening vignette. The immediate, almost reflexive instinct for a lot of clinicians looking at an infected lung is to grab the prescription pad and start antibiotics.
Oh, without a second thought, usually.
Exactly. But the new guidelines force us to hit the brakes and look very closely at the clinical setting. We are suddenly staring down a massive antibiotic stewardship dilemma.
It is arguably one of the most challenging cognitive shifts for a clinician to make on shift.
Why is that?
Well, we see the word pneumonia in the chart, we look at a patient coughing up sputum, and our deepest instinct is to actively do something to eradicate it. But knowing the patient has a confirmed respiratory virus changes the entire therapeutic calculus.
Okay, let's break down the evidence and the actual risk of harm here. The ATS gives a very specific suggestion to not prescribe empiric antibiotics for adult outpatients without comorbidities who test positive for a respiratory virus.
Right, which is a big shift for some.
It is. Now, again, the certainty of evidence here is categorized as very low.
Okay.
But the driving force behind this recommendation isn't necessarily proof of efficacy. It is the robust proof of harm from unnecessary antibiotic exposure.
Exactly.
We are talking about severe allergic reactions, adverse renal or hepatic events, and of course, the ever-present devastating threat of a C. diff infection.
Which nobody wants.
Nobody. But the contrast is what makes this so complex. If that exact same patient is admitted to the hospital, whether they are classified as having non-severe or severe CAP, the recommendation completely flips.
It does.
For inpatients, the guidelines suggest prescribing empiric antibiotics despite that positive viral swab.
It seems highly contradictory on the surface until you dig into the pathophysiology and the frontline reality of bacterial co-infections.
Right.
What's fascinating here is how the guidelines force us to stratify risk. If you are looking at an otherwise healthy outpatient with a confirmed virus, the statistical odds that they also have a superimposed bacterial infection are relatively low.
Yeah.
In that specific scenario, the risk of destroying their gut microbiome and giving them a life-threatening C. diff infection far outweighs the risk of missing a secondary bacterial pneumonia.
That makes total sense.
But even in the outpatient setting, the moment you are dealing with a patient who has significant comorbidities like COPD, congestive heart failure, or poorly controlled diabetes, or if they show clinical red flags, that script flips right back to antibiotics.
Because of the lung damage.
Exactly. The viral infection damages the ciliated epithelial cells in the airway, stripping away the lung's natural defense mechanism, making those vulnerable patients a prime target for bacterial superinfection.
It really operates like a sliding scale of disaster.
A sliding scale of disaster, I like that.
Right. The stark line between outpatient and inpatient isn't about the physical geography of the hospital. I mean, the patient's underlying biology doesn't magically mutate while they're riding the elevator up from the emergency department to the medicine floor.
No, of course not.
So the approach changes because the very fact they crossed the threshold to become an inpatient means their intrinsic severity is exponentially higher. They were admitted because their vital signs were unstable or their oxygen requirements spiked, which drastically increases the pre-test probability that a bacterial co-infection is already wreaking havoc on their lungs.
That is the exact mechanism driving the divergence. The severity that dictated their admission is the red flag itself.
Right.
When you are evaluating an outpatient and trying to decide where they sit on that sliding scale of disaster, you have to look for very specific historical and clinical indicators. You want to ask the patient about the classic double sickening phenomenon.
Oh, it's a double sickening.
Yeah. Did they get a typical viral cold, start to feel slightly better for a day or two, and then suddenly get hit like a freight train with a high fever, shaking chills, and a terrible cough?
Right, that biphasic illness.
Exactly. That biphasic illness is the clinical hallmark of a bacterial superinfection, taking advantage of the virally damaged respiratory epithelium. You also need to look for purulent sputum, or check if their inflammatory markers, like procalcitonin or white blood cell counts, are spiking.
And if they are?
If those frontline indicators are present, the risk of withholding antibiotics is simply too immense, regardless of the viral swab you have to treat.
So assuming we have weighed all those risks, we've factored in the comorbidities, we've looked for the double sickening, and we make the definitive call that this patient absolutely requires antibiotics.
Right.
The immediate next question, and one that is undergoing a massive paradigm shift in these guidelines, is for exactly how long do we treat them?
Oh, man. This is a space where we are seeing a major systemic push toward much shorter antibiotic courses.
Which is great.
Historically, the dogma was to give everyone 7 to 10 days, and sometimes a full 14 days, just to be thorough. But the new guidelines are aggressively pushing for less than 5 days, with a strict minimum of 3 days, specifically for clinically stable outpatients and non-severe inpatients.
It is a profound shift from the traditional marathon mindset to a sprint. We are asking clinicians to hit the infection hard and fast and then pull back.
Yeah, and that's hard for people to do.
It really is. I want to explore the deep psychological anxiety that creates for the prescriber. Aren't doctors conditioned throughout their entire medical training to prescribe 5, 7, or 10 days just to be safe?
Absolutely.
There is an immense fear of stopping at day 3 and having the patient relapse. But how does that just to be safe mentality actually expose the patient to unnecessary harm?
Because every single additional day of broad-spectrum antibiotic exposure acts like carpet bombing on the patient's microbiome.
Wow.
It wipes out the commensal beneficial gut flora that naturally outcompetes pathogens. That false sense of security is actively damaging. By giving days 4, 5, and 6 to a stable patient, you are providing zero additional clinical benefit to the lung tissue, but you are introducing a near 100% chance of further microbiome disruption, drug toxicity, and promoting antimicrobial resistance on a population level.
So if they are stable at day 3?
If a patient has achieved true clinical stability at day 3, meaning their heart rate is settled, their respiratory rate is normal, their temperature is broken, and their oxygen saturation is stable on room air, the antibiotics have fully done their job.
They've knocked the bacterial load down.
Exactly, down below the critical threshold. At that point, the patient's own functional immune system is fully capable of sweeping up the remaining debris.
But there are exceptions, right?
Oh, absolutely.
All right.
We have to acknowledge the major bedside barriers that complicate this short course recommendation. You can't just blindly stop at 3 days for everyone. If you suspect, or if the lab cultures grow, an organism that notoriously requires longer durations to eradicate, like Pseudomonas aeruginosa, MRSA, or an intracellular pathogen like Legionella, you absolutely must extend the course.
That makes sense.
Furthermore, and this is a massive issue when you are discharging a patient, short courses demand reliable follow-up.
Right, because the guideline assumes the patient can accurately monitor their own trajectory.
Yes.
When you discharge that patient with only 3 days of pills, you are heavily relying on them to recognize if their respiratory rate starts creeping back up. If the patient has barriers to self-assessment, cognitive decline, or if there are language and socioeconomic barriers preventing rapid follow-up communication, a 3-day course could leave them stranded if they happen to fail therapy.
Exactly. It's a huge systemic risk.
The contrast with severe inpatients is incredibly stark here, too. For severe CAP, the ATS pivots completely and makes a strong recommendation for 5 or more days. And what is structurally fascinating about the guideline is that they issue the strong recommendation while simultaneously admitting the supporting evidence is of very low quality.
Yeah, they do.
They justify it by stating point blank that insufficient therapy in severe CAP can directly result in death.
Yeah, and when mortality is the primary outcome on the line, the risk-reward ratio shifts dramatically.
You accept the collateral damage.
You accept the collateral damage to the microbiome because a relapse in a patient who is already on a ventilator or in septic shock is a fatal event. You cannot risk the 3-day sprint when the patient's systemic reserve is completely depleted.
That sets up our final and perhaps most intense clinical intervention. For our absolute sickest patients, those severe inpatients languishing in the ICU on those extended 5+ day antibiotic courses, we have to consider systemic adjunctive therapies to help them survive the physiological toll.
Right, the adjunctive therapies.
We are talking about the overwhelming inflammatory storm that pneumonia triggers. Do systemic corticosteroids help calm the storm, or do they ultimately hurt the patient?
This specific intervention is perhaps the most highly debated, specific, and divergent section of the entire 2025 guideline update.
I believe it.
Corticosteroids are the ultimate double-edged sword in pulmonary medicine, and the ATS has finally drawn very sharp, heavily defined lines on exactly when clinicians should draw that sword.
So what does this all mean for the non-severe inpatient on the medical ward? The guidelines issue a strong recommendation against administering systemic corticosteroids for non-severe CAP.
Strong recommendation against.
Yes. And again, we look at the balance of evidence. While the overall quality of evidence for any efficacy or benefit is incredibly low, the evidence for the harms of steroids is robust and well documented.
Of hyperglycemia.
Exactly. The primary villain driving this recommendation is hyperglycemia. When you give high-dose systemic steroids to a non-severe patient, you dramatically spike their blood sugar.
Which is terrible for healing.
Terrible. That hyperglycemia directly impairs neutrophil chemotaxis, meaning the immune cells can't travel to the site of infection effectively. It paralyzes the immune response, feeds the metabolic demands of the pathogen, and severely complicates the patient's recovery trajectory, all while offering zero mortality benefit to offset that physiological harm.
So it is a definitive no for the non-severe ward patient. But the entire paradigm shifts the moment that patient crosses the threshold into severe CAP.
Okay, tell us about that.
For adult inpatients actively suffering from severe CAP, the ATS issues a conditional suggestion for the use of systemic corticosteroids.
For their use.
Yes. But we must be incredibly precise here because there are critical, non-negotiable exceptions.
What's the biggest one?
The most vital exception is that this recommendation strictly, absolutely excludes patients whose severe pneumonia is driven by the influenza virus.
Wait, really? Why?
Because extensive data shows that administering systemic steroids in severe influenza pneumonia actively increases mortality and exponentially raises the rate of secondary hospital-acquired bacterial infections.
Wow, so no steroids for flu.
Absolutely not. Assuming you have ruled out influenza, you then have to look at the frontline criteria that actually strengthen the case for using steroids. We are looking for patients who are critically ill in the ICU, specifically those with severe respiratory failure.
Meaning what, exactly?
Meaning their PO2 to OO2 ratio, their P to F ratio, has plummeted below 300, showing their lungs are severely struggling to transfer oxygen into the blood. We also want to see highly elevated inflammatory markers like CRP or IL-6, which tells us that a massive destructive cytokine storm is fully underway.
So the intervention has to match the specific phase of the disease. But there is a massive logistical catch regarding the timeline, and it feels like an incredibly tight, rapidly closing window.
Oh, the 24-hour rule.
Right. The guidelines emphasize the absolute necessity of administering these corticosteroids early, specifically within 24 hours of the patient meeting those strict criteria for severe CAP.
Yeah, timing is everything.
Why this strict 24-hour window, though? I mean, if giving steroids at hour 72 suddenly weakens the recommendation, how does that shift the risk-reward balance?
Well, the reasoning here ties perfectly into the pathophysiology of the immune response. That initial 24-hour window represents the explosive peak of the hyperinflammatory phase.
The cytokine storm.
Exactly. The invading bacteria have triggered a massive, unregulated cytokine storm. It is often the inflammation itself, the protein-rich fluid leaking into the delicate alveoli, the overactive immune cells literally destroying healthy lung tissue that is killing the patient, not just the pathogen.
So the steroids act like a fire extinguisher.
Yes, if you administer high-dose steroids inside that 24-hour window, you aggressively blunt that deadly inflammatory cascade. But let's say a patient gets transferred from a rural community hospital, there is a transport delay, and they arrive at your ICU 72 hours into their severe illness.
The window is closed.
Exactly. The biology of the battlefield has fundamentally altered. The immune response is dynamic, not static. By hour 72, the initial hyperinflammatory peak has likely passed.
Right, they're moving into the next phase.
The patient's immune system is transitioning into a reparative phase. The macrophages are shifting their focus to clearing the lingering infection, phagocytizing dead tissue, and beginning the slow process of lung repair.
So if you give steroids then?
If you introduce a massive dose of immunosuppressive steroids at day 3 or day 4, you aren't blunting a cytokine storm anymore. The storm has passed.
You're just halting the cleanup crew.
Exactly. You are just paralyzing the immune system at the exact moment it needs to be sweeping up the cellular wreckage. That drastically increases the risk of a secondary, highly resistant, hospital-acquired bacterial superinfection taking root in the damaged lung. The therapeutic window slams shut because the disease phase has moved on.
It is such a vital concept to grasp. It isn't just about choosing the right drug from the pharmacy. It is about delivering the right drug at the exact right biological hour.
Completely agree.
Well, we have covered a tremendous amount of ground in this deep dive, navigating everything from the physical mechanics of ultrasound waves to the intricate timing of the immune system's reparative phase.
It's a lot of information.
It is. So as we wrap up, let's step back and weave this dense data into how it actually changes your workflow tomorrow morning. Let's hit some bedside pearls.
Perfect. If you take nothing else away from this ATS update, let the focus on precision and reevaluation guide your practice. We are moving away from the old dogma of one size fits all.
Definitely.
Lung ultrasound is a brilliant radiation-free tool that can speed up your triage, but you have to respect its limitations.
Right.
If you don't have the specific training, or if the patient's body habitus is fighting you, don't force it. Stick to the chest x-ray.
Right. And when you are looking at that viral swab, remember that a positive test doesn't automatically give you a free pass to withhold antibiotics. If you are discharging a young, healthy outpatient, absolutely prioritize stewardship and holding antibiotics. But the moment you see comorbidities, signs of a biphasic double sickening, or if the patient is sick enough to require admission to the hospital, you have to assume a bacterial co-infection is in play and treat accordingly.
And when you do treat, the push is aggressively toward shorter durations. We want to protect the patient's microbiome.
The 3-day sprint.
Yes, but whether you are utilizing the 3-day sprint for a non-severe patient or the mandatory 5-day marathon for a severe ICU patient, the entire concept of duration hinges on one absolute truth. You can no longer put pneumonia treatment on autopilot.
No more set it and forget it.
Exactly. Shorter courses are only safe if they are strictly guided by evaluating the patient's clinical stability, their heart rate, temperature, respiratory rate, aimantation, every single day.
Which brings us to a final provocative thought to mull over as you head into your next shift.
Let's hear it.
The guidelines are pushing us hard toward these shorter 3-day antibiotic courses in outpatients to practice excellent antimicrobial stewardship. But the absolute non-negotiable prerequisite for stopping at day 3 is a daily assessment of clinical stability.
Right.
In an outpatient setting, we are entirely reliant on the patient to perform this assessment. So how do we effectively empower outpatients to accurately self-assess their own respiratory rate, recognize subtle temperature shifts, or notice mild cognitive declines at home?
It's a massive challenge.
Especially when they face deep barriers to health literacy or language? Are we building a modern, evidence-based guideline on the fragile assumption that a sick, exhausted patient sitting at home can successfully act as their own bedside nurse?
It's a profound clinical tension, for sure.
It is, and it's something we all need to navigate carefully when planning a discharge. Well, thank you for joining us on this deep dive.
It's been great.
Remember to like, subscribe, and share this with your peers so we can continue to elevate the standard of care across our clinical community. Until next time, trust the evidence, but always treat the patient sitting right in front of you.